Good evening. Today we will see infertility as given in speroff's textbook. So first we will go with the definitions. What is fecundability and fecundity? Fecundability means the probability that one cycle can result in pregnancy. Fecundity means the probability that one cycle will result in live birth. So what does aging has to do with fertility? Because of increasing age, the stamina decreases and the interest in sex decreases, the coital frequency decreases, other infections, PID, leiomyoma, endometriosis, all these conditions increases, subclinical abortions will increases. So in female, the peak fertility age is 20 to 24 years. As the age advances, you can see that there is a drop in the fertility. So if you see between 25 to 29 years, the less fertility is 8% less than what they were in 20 to 24 years. When the age comes to 30 to 35 years, the fertility when compared with 20 years, it is 20% lower. 35 to 39 years is almost 45% lower, and when the women goes to the age of 40 to 45 years, you can see 90% of the fertility is lesser when compared with the to 2024 years. One point has to be noted down is this fertility and this aging is only for the females. For males there is no such tabular column showing drop in fertility. So up to 45 years almost the fertility remains the same for men, whereas for females it drops just 10, 20, 40 and 90% lower as she advances in age. And also as the age increases, the rate of miscarriage increases. See, in less than 30 years the spontaneous miscarriage will be 7 to 15%. As the age increases, I can see when it is 40 plus, it's 50%. So from 15 to 50% in just a period of 10 years, it's such a drastic thing. So what is happening with aging in our body? First we'll see the ovary. In ovary what is happening? The follicle is going for atresia. So when the baby is in utero, it is having 6 to 7 million follicles, primordial follicles. It will be 1 to 2 million in birth, be arrested in the prophase of second meiosis, and at puberty it will be lakhs. So millions and the lakhs at the 3 to 4 lakhs at puberty. During the fertile period, she'll be having around 25,000, and at menopause, hardly 100 to thousands. So there is drop in follicle. Follicle depletion is happening with aging. Second thing is there is monotropic rise in FSH. So when the FSH comes and stimulates the ovary has to produce estrogen, and that estrogen will go and stimulate, provide a negative feedback to the pituitary. But this is not happening in the aging. See what happens, the follicles or atresia, going for atresia, so the number of follicles is low, more amount of FSH are coming to stimulate the ovaries, but because they are atretic they cannot stimulate they cannot produce the ovarian hormones, so less ovarian hormones, less feedback, so there is monotropic rise in FSH, but the LH remains unchanged, and this results in loss of pulsatility and loss of fertility. So then because of aging, accumulation of genetic mutations and that manifests in fertility. So you see the mutations are happening in FSH receptors, LH receptors, CYP17 and 19 or something related with the steroid synthesis pathway, GDF9, BMP15, GPR13, LHX8A. All these are in accelerating the follicular depletion. So there was a study, genome-wide association studies, and they identified clusters of loci on chromosomes 5, 6, 19, 20 and 13 that determines the age at menopause. We all know some people attain menopause by 56 years, some by 45. They are all genetically determined and they are located in the chromosome 13, mainly 13. And this is a beautiful graph. See, you can see the blue color thing that is falling in the follicles. As the age advances, there is drop in the follicles. So abnormal oocytes, uh, uh, abnormal oocytes will be 25, 50, 70, 100% in the age 50 years. So no normal graphene follicles will be absent. So the peak fertility is between 20 to 24, and also from 25 to 30. The fertility starts declining after 30 years of age, and you can see the menopause. This. So what is with the uterus? Uterus, there is no much change except that she can acquire fibroid. If it's in submucous fibroid, it will distort the cavity and it can prevent the implantation of the fetus. And if adenomyosis is there, she may not be having a regular cycles and can also impair implantation. In males also, because of aging, they can accumulate the epigenetic changes, and that can be seen in the sperm. So this point in red is taken directly from the textbook. That is, there is little or no overall measurable decline in male fertility before 45 to 50 years. So what we've seen there, so the tabular column that shows loss in the fertility as the age advances is only for females and not for the males. This is a statement from speroff. Okay, so now we'll assess the ovarian reserve. So only two intentions we have: how much pool is there, follicular pool, and how well do they respond to the gonadotrophins if we stimulate. These two things we have to know when you are going for an assessment. So first, serum estrogen. Because estrogen is produced from ovaries, do they indicate the follicular load? No, there is no, because there is some peripheral conversion and also some contributions from the adrenals. So this serum estrogen is no use in assessing the ovarian reserve. Serum FSH on day 2 to 4 more than 10 indicates poor response to stimulation. It has sensitivity of only 10 to 30%, whereas specificity is 80 to 100. So if it's more than 10, that means there will be poor response, and if it's less than 10, if it's normal range, that does not indicate that the pool is adequate. CCC, that is clomiphene citrate challenge test. So what they're doing is they measure day 2 or day 4 of FSH, and then from day 5 to day 9 they give 100 milligram clomiphene citrate OD for 5 days, and then on day 10 they measure the FSH. If on day 10 the FSH is still more than 10, it indicates failure to treatment. They respond very poorly, so they need donor eggs or something like that. Inhibin B. So what is inhibin B? It is a substance produced by granulose cell of small antral follicles in the follicular phase. It has no relevance with ovarian reserve. So it has only low positive predictive value, that is only 20%. So it is no use in assessing the ovarian reserve. Then is our AMH, anti-Mullerian hormone. This is again produced by granulose cells of the pre-antral and early antral follicles. So the follicles having 2 to 6 mm diameters will be producing this AMH. So because they are the early antral, they represent the pool. They are not from the dominant follicle that is about to ovulate or rupture. No, they are from the follicles before the stages of ovulation. So they represent the pool, and they are gonadotrophin independent, and they exhibit little variation between the cycles. So it is well useful to analyze the ovarian reserve. So low reserve means it is 0.2 to 0.7 nanogram per ml, and it indicates that the treatment is going to be failure with gonadotrophin stimulation. And then is the antral follicle count. This is something done with the ultrasound. So each ovary will have at least 100 to 150 follicles, at least one more than 2 mm. So antral follicles or something having the size of 2 to 10 mm. We all count these follicles, and we have to correlate with the fertility range. Last one is ovarian volume. So ultrasoundly we measure the length, width and depth, and we multiply it by 0.52. If it comes less than 3 ml, they are poor response to gonadotrophins. So we have to go for a donor egg. Thank you.